For those of you joining early, I wonder, Casey, if we might want to just show the translation slide. So if folks want to initiate the French interpretation, they can. We will have French interpretation on this webinar. If you are listening in English, you don't have to do anything. Just leave the settings as they are. But if you would like to hear simultaneous translation in French, you can hit on the interpretation icon on your screen. It looks like a little globe. And when you select that, you can select French, and you also have to select mute original audio. And that way you will be able to hear me speaking in French. Bonjour. We're just at the top of the hour, but I'm just going to give it a minute for a few more people to join. Okay, I think we could go, let's see, we can go back to the beginning. There we go. All right, I'm going to go ahead and launch. My name is Christine Toriuson. I'm from FHI 360, and I'm the co-director of the Choice Collaboration, which hosts the Global PrEP Learning Network. We're very happy to have you here today to discuss event-driven PrEP. Next slide, please. This is our agenda. We're going to hear an overview of event-driven PrEP, and then we're going to hear about the experience in Thailand. And we'll have ample time for Q&A as we go through. Please note that we do have French interpretation on this webinar today. If you are listening in English, you don't have to do anything. But if you would like to hear this presentation in French, you can click on the interpretation icon and select French, and also select mute original audio. If you have any questions at all just about the translation, please put them in the chat and we will help sort out any technical issues. Next slide, please. So I'm very pleased to welcome today our speakers. We have Gaston Djomand from the CDC. He's a medical epidemiologist in the Division of Global HIV, AIDS, and TB, and he supports PrEP implementation in Uganda, DRC, Cote d'Ivoire, and Haiti. We also have Chris Obermeyer, who is a biomedical prevention advisor at USAID, where he supports PrEP, PEPFAR implemented PrEP programming in West Africa, Ethiopia, Namibia, and Asia. And we are also pleased to welcome Greg Carl from the Institute for HIV Research and Innovation. He is a senior capacity building supervisor there in Bangkok, Thailand, and has been working in the field of HIV and AIDS for 34 years. Next slide, please. So this is just a friendly reminder to please use the chat function. This is a webinar where unfortunately we do not have audio capability for our attendees. However, we do welcome and encourage comments and questions in the chat. Please remember to go to when you're writing in the chat, go to the to button and hit the little arrow and select all panelists and attendees so that everyone can see your comments. Unfortunately, the default is to all panelists. So if you go with the default, only the panelists will see your questions and comments, and we want everyone to be able to see. So to the extent that you can, please select all panelists and attendees for your chat. Next slide, please. Just one more reminder on the French interpretation in case there are a few people who have joined after my last discussion of this, but if you would like French interpretation, please select the interpretation icon, select French, and select mute original audio. Next slide, please. Okay, I think we are ready to launch, and I'm going to turn this over to, I believe, to Chris Obermeyer first, or Gaston?
Gaston.
Okay, Gaston, take it away.
All right. Okay, thank you, Kristen. Good morning, good afternoon, good evening, everybody. Welcome to this session. It's my pleasure to talk with you about event-driven oral pre-exposure prophylaxis, or ED-PEP. So my name is Gaston Djomand from CDC, and I will be co-presenting with my colleague, Chris Obermeyer from USAID. This session is designed to be a learning session, and Chris and I will go over some didactic concept along with some case scenarios that may help you learn and understand more about ED-PREP. So this webinar is being recorded, and the recording will be shared along with the slides at a later date. Next slide. So by the end of this session, we would like all attendees to be able to define event-driven PrEP, to identify candidates for ED-PREP, to explain how to take ED-PREP effectively, to describe advantages and disadvantages of ED-PREP, to consider policy and programmatic changes needed to implement ED-PREP, and lastly, identify resources for development of ED-PREP implementation tools. Next slide. So before we dive into the webinar, it's important to make a quick note about the terminology that is going to be used throughout this webinar. So the term women refers to both cisgender and transgender women, and the term men refers to both cisgender and transgender men. For those who want more information on sexual orientation and gender identity, they can click on the link at the bottom of the screen, and they will be directed to the PEPFAR Gender and Sexual Diversity Training, where they will have more information. Next slide, please. So event-driven PrEP or ED-PrEP refers to an additional regimen for men who have sex with men or MSM only, where 2 pills of TDF-FTC or TDF-3TC are taken 2 to 24 hours before sex. This is called the loading dose, and this is followed by 1 pill 24 hours after the loading pill, which is actually the 3rd pill, followed by 1 more pill 24 hours after that 3rd pill, which constitutes, the 4th pill. So ED-PrEP may also be referenced as on-demand, event-based, or intermittent, or 2+1+1. If you see all those terms, it's all the same. Now let's illustrate what I just described with this little schema on the right-hand side of this slide. Let's say I'm supposed to have sex on Friday night at 11, and I want to use ED-PrEP to protect me. So on this schema, sex is represented by this little smiley face with a wink. So I would take 2 pills on Friday morning at 9 a.m. as my loading dose. I will have my sex encounter on Friday night at 11 p.m. On Saturday morning, I will take 1 pill, that is the 3rd pill. And on Sunday morning, I will take the last pill. So that would be 4 pills to cover my sexual encounter of Friday night. So I'm sure many of you wonder what to do if I have multiple encounters throughout the weekend. So my colleague Chris will cover all those situations later in the webinar. Next slide. So now let's see the current approval status of event-driven PrEP. The World Health Organization issued a technical brief at the international conference in July 2019 to update the dosing consideration of oral PrEP for MSM. And that technical brief is called what is 2+1+1? And the technical brief can be accessed online, and it's actually included in the resources section of this slide deck. So TDF, FTC, or 3TC as PrEP used intermittently has not yet been approved by FDA or CDC. However, country-specific guidelines may need to be updated to allow for and include ED-PrEP. Next slide. So PEPFAR currently supports the implementation of event-driven PrEP and has included the recommendation, the WHO recommendation in the COP21 guidance. It's at page 249 and 250. And it specifically states that countries with oral PrEP programs supporting MSMs and supported by PEPFAR should address the policy and programmatic changes to make ED-PrEP available for MSM. As we all know, MSM continue to be a target for global scale-up of PrEP, and ED-PrEP may strategically increase PrEP uptake and continuation among MSM. Next slide. Now let's talk about the evidence behind the efficacy of ED-PrEP. It actually relies on two landmark studies conducted over the past 5-6 years. The first study is the Hypergay trial conducted in France and Canada, and it enrolled approximately 400 participants and randomized them in ED-PrEP or placebo. And the study documented a risk of acquisition reduced by 86%. During the same study, in the open label extension of that study, the risk of acquisition was reduced by 97% among subjects who reported less frequent sex and used ED-PrEP. So the second study was started in 2017, and it's called the Prevenir study. It is a large ongoing demonstration project in France where clients use daily or ED-PrEP. And the results over 3,000 participants showed no incident infection in the oral and ED-PrEP groups. More than half of MSM actually preferred ED-PrEP over daily PrEP in that demonstration project. The two other studies are showing evidence that ED-PrEP can safely be implemented in real life and can actually represent a powerful HIV prevention tool for MSM. So in the interest of time, we're not going to go through it, but it's available and you can refer to it when you have the slide deck. Next slide. So who are the appropriate clients for ED-PrEP? Event-driven PrEP is appropriate for a man who has sex with another man, who finds ED-PrEP more convenient, who has infrequent sex, which is defined as sex less than 2 times per week on average, a man who is able to plan for sex at least 2 hours in advance, or who can delay sex for at least 2 hours. Now, event-driven PrEP is not appropriate for the following persons: women, transgender men having vaginal frontal sex, men having vaginal and or anal sex with women, and people with chronic hepatitis B infection. So basically, the take-home message from this slide is that evidence suggests that ED-PrEP only protects MSM from HIV transmission during anal sex. Next slide. So ED-PrEP is not for everyone. To date, no trials have included anyone under 18 years of age, so we do not know how effective it is among young persons or adolescents. Also, there is not enough evidence to indicate that ED-PrEP is safe and effective for women, transgender men having vaginal and frontal sex, men who have vaginal and or anal sex with women, and the pharmacokinetics of tenofovir in the vaginal mucosa suggests that ED-PrEP may not give enough protection for receptive vaginal frontal sex. And the interaction of PrEP and gender-affirming hormones in transgender women suggests a lot of caution with ED-PrEP, as it may result in decreased levels of tenofovir that are necessary to protect from HIV infection. So next slide, let's do a quick knowledge check. So ED-PrEP is effective at preventing HIV transmission for MSM during which of the following behavior? Sex with women, sharing equipment while injecting drugs, sex with men, or all of the above? Kristen, tell me when you close the poll.
People
Casey?
are still voting quickly, so I was going to give them a few more seconds. So a lot of people are still voting.
We have like 180 people on the call, so I guess it's a lot of responses. But I think you could go ahead and share, Casey.
Okay. All right. So I think the right answer, most of people found the right answer. It's sex with men. The right answer is C. So next slide. So how to start and stop PrEP for MSM only? So to simplify dosing recommendation among people who stop and restart PrEP, and to be more cautious, the daily PrEP can be started with a loading dose of 2 pills. And this is actually highlighted in the WHO guidance, what is 2+1+1, that was issued in July of 2019. For ED-PrEP, it should always start with a loading dose of 2 pills each time, 2 to 24 hours before any sexual encounter. And to stop PrEP, whether you are on daily or event-driven PrEP, to do it appropriately, it requires that you take a pill for 2 consecutive days after the last time you had sex. A pill for 2 consecutive days after you have had the last time you have had sex. So now I will turn to my colleague Chris to go over some very exciting scenarios. Chris, take it away.
Great, thanks, Gaston. On the next slide, we'll go over a simple scenario. So this is a common one in terms of sex. And so Duke lives in Vietnam. On Friday night, Duke plans to invite someone he met on Grindr over to his place and plans to have anal sex. He takes 2 pills, which are the loading dose of PrEP on Friday morning at 9 a.m. and has sex Friday night at 11 p.m. He takes a 3rd pill on Saturday at 9 a.m. and a 4th pill on Sunday at 9 a.m. So this is a typical scenario that we see in a lot of places with a lot of materials where MSM are taking 2 pills 2 to 24 hours before having sex, and then 1 pill each of the following days. On the next slide, we have a different scenario. And here we have Kwame, who lives in Ghana. His wife is going to Accra to visit her family on Friday and coming back Sunday night. Kwame sometimes has sex with his male friends, who he is planning to hang out with on Friday and Saturday. Kwame takes 2 pills, that loading dose on Friday morning. He has sex Friday night and takes 1 pill on Saturday morning. Saturday night, he has sex again, then again Sunday morning. Kwame takes 1 pill of PrEP on Sunday and Monday and Tuesday mornings at 9 a.m. So in this scenario, MSM who have sex over multiple days are going to continue taking 1 pill each day for 2 days after the last time they've had sex. So here you see, a total of 6 pills used over 4 days. In the next scenario, we'll look at sex on multiple non-consecutive days. So we have Jose, who is gay and lives in Guatemala. Jose has a date on Friday night and hopes to have sex. He uses event-driven PrEP. He takes 2 pills Friday morning before having sex on Friday night. On Saturday and Sunday, he takes another pill each day. On Sunday, he meets up with his date again, and they have unplanned sex. So he continues taking a pill each day on Monday and Tuesday. So MSM who have sex on non-consecutive days while still taking ED-PrEP should continue taking 1 pill each day for 2 days after the last time they've had sex. So let's do a quick learning check, a knowledge check on the next slide. So how many hours before sex should MSM take the loading dose of PrEP when using event-driven PrEP? So a poll is on your screen. So let's give you about 30 seconds to answer that one. All right. Great. So MSM taking a loading dose of PrEP should indeed take it 2 to 24 hours before having sex. Great. Let's go on to the next slide. So a common question we get is about MSM who are switching between daily and event-driven PrEP. And so with WHO guidance, MSM can switch between daily and event-driven dosing and vice versa, depending on the needs of MSM. So on the next slide, we've given a scenario where you can see MSM switching from ED-PEP to daily PrEP. So Alex has been taking ED-PEP for several months. Next week, he plans to go to a nearby city to sell sex and make some money at a popular holiday location. Alex isn't always able to negotiate condoms with his clients, so he decides to switch to daily PrEP. Alex takes 2 pills, which is a loading dose of PrEP on Sunday, and then continues taking a pill each day while he's working. He has sex several times throughout the week with different clients. On Saturday night, Alex has sex, and on Sunday, he heads home. Alex takes PrEP on Sunday and Monday, and then can stop taking PrEP if he wants to. So this is a scenario where Alex is switching from event-driven PrEP to daily PrEP due to changes in sexual activities. So on the next slide, we have Alex is back home, and Alex is planning to meet up with a regular partner on Thursday afternoon. And so now he has stopped taking daily PrEP, and he is switching back to ED-PEP. So he's going to take 2 pills on Thursday morning at 9 a.m. and then continue taking 1 pill each day on Friday and Saturday until he thinks he's going to have sex again. So on the next slide, let's talk about some of the advantages of event-driven PrEP for MSM. So one of the advantages is that it provides MSM an additional dosing option for those who are taking oral PrEP. During COVID-19, we've seen an increase of people, we've seen an increase of MSM who are asking for event-driven PrEP as some of their needs for kind of like daily oral PrEP have changed. Event-driven PrEP may reduce the drug costs, especially where those maybe clients are procuring PrEP on their own. It also may reduce the pill burden in terms of how many pills they need to take. And here we're seeing that it may increase the uptake of PrEP. It may increase kind of like long-term PrEP continuation. So because MSM can choose when to take event-driven PrEP. So in places where event-driven PrEP is implemented and used, event-driven PrEP should not be the only option available for MSM. We want to stress that MSM should continue to have the choice between event-driven and daily oral PrEP. So on the next slide, ED-PEP also comes with some disadvantages. Planning before sex is needed. So MSM may not always be in situations where they're able to plan and anticipate sex or delay sex at least 2 hours and taking that loading dose. It's also important, just like with the oral PrEP, that clients must remember to take all the doses in the correct way. One thing we're seeing is that there's a lot of interest in kind of tracking who is taking daily versus event-driven PrEP. And if programs choose to identify those individuals, it could identify MSM within their programmatic documents. It may also not necessarily be valuable, as MSM may choose to switch between daily and ED-PEP without coming in for clinic visits. MSM who start ED-PEP are more likely than MSM using daily PrEP to develop resistance if they start PrEP during acute HIV infection. So again, highlighting the importance of assessing for AHI during PrEP initiation. So Another disadvantage is that the incentive to come in for monitoring visits, those quarterly monitoring visits may be reduced because clients won't always need a refill every 3 months. We also don't have any evidence that event-driven PrEP prevents HIV transmission when MSM have sex with women or when they inject drugs. On the next slide, we're going to go ahead and do another knowledge check. So which of these is a disadvantage of event-driven PrEP? All right, let's see what the answers are. Great, so that's one of the key disadvantages of event-driven PrEP is that clients must remember to take all the doses in the correct way. This is why we think some of the visuals we've used in this presentation might be particularly useful in order to help clients understand how to take PrEP effectively. On the next slide, we've looked into developing some considerations for monitoring visits. So the frequency of visits should continue to follow the same frequency and procedures as anyone taking daily oral PrEP. So a recommended visit at 1 month and then 3 quarterly visits thereafter. In terms of prescription and refills, we have to make sure that TDF-FTC or TDF-3TC are the only drugs currently recommended by the WHO for event-driven PrEP. FTAF or other formulations are not yet approved by WHO for event-driven PrEP. Another part of the prescriptions refills is that clients may not need a refill at each monitoring visit. One of the recommendations we have is that clients should have enough pills between visits should they choose to use PrEP on a daily basis. Some of the counseling considerations is that in some settings, it may be valuable to educate all men about event-driven PrEP, especially in settings where MSM are unlikely to disclose same-sex activities. So, only discussing event-driven PrEP with MSM who disclose that they have sex with men may not be able to reach all MSM who might benefit from event-driven dosing. It also may be important in some settings to inform women that event-driven PrEP is not yet known to be effective for them. In the next slide, we've included some special considerations for PEPFAR. In terms of reporting, reporting on MER indicators remains unchanged. All PrEP regimens currently are reported through PrEP-New and PrEP-Cur, those 2 indicators. And we wanted to highlight again that since clients may switch between daily and event-driven PrEP, identifying clients in records as daily or event-driven PrEP users and programmatic data may have very little practical value, and there may be a risk of social harms. Let's do one more knowledge check. So how should ED-PrEP users be reported into DATAM? So this is the PEPFAR reporting. So should they be reported as PrEP-New and PrEP-Cur? Should they be reported as ED-PrEP-New and ED-PrEP-Cur? Or you don't have a clue? All right, we can close this one, I think. Great. So it's going to be under PrEP-New and PrEP-Cur. So there are no new indicators that have yet been proposed or disaggregates for tracking event-driven PrEP use, as MSM may switch between daily and event-driven PrEP. With that, I will turn it over to Gaston for some conclusions.
Thank you, Chris. In conclusion, I think we would say that the evidence of effectiveness and safety of ED-PrEP among MSM is quite compelling when taken as prescribed. It is an additional dosing option for MSM, which may increase actually PrEP uptake and continuation in PEPFAR programs. We think that policy and programmatic changes are needed in order to sort of effectively implement ED-PrEP. And I think education about ED-PrEP is actually key to implementation and effectiveness in programs. Next slide. So what are the next steps? So we think countries may need to update their guidelines to include ED-PEP for MSM. We also think that training for PrEP providers should include accurate information about ED-PEP. And lastly, we think that counseling tools for PrEP should also include a counseling component on ED-PEP. So with that, I will turn into Chris to talk about the resources for ED-PEP.
Thanks, Gaston. So I'm going to go through some of the a group of resources that we have put together. So on the next slide, so we have put together, I want to highlight this, which is template language for event-driven PrEP. And so I think in November, Choice launched on PrEP Watch in English and French guidelines for daily oral PrEP. And here's template language for event-driven PrEP. These are aligned with WHO guidelines, as is the content of this presentation today. And so those are available in English and French, and these are made to be guidelines that countries can adopt to help speed up the implementation and acceptance of event-driven PrEP. On the next slide, another common topic we get asked for resources about is about training for providers. And so these slides will be available in English and French after the session for you to download and can be used as part of training materials for event-driven PrEP for providers. But the WHO Chipago Oral PrEP e-learning course, which is available for free online at hivoralprep.org, does include event-driven PrEP and some considerations for providers. We've also collected on the next slide a number of resources from the US, from San Francisco and New York City, and from the California Department of Health on event-driven PrEP. And then we've also compiled in the next slides a number of international examples. So videos in Bambara and French, some information from the UK. On the next slide, we have a number of resources that are available in English and in French from our French NGO. And then we've also have on the next slide, next two slides, some examples from Australia. On the next slide, there's one that I do want to point out here, which is a useful tool that might be modified in terms of figuring out whether event-driven PrEP might be appropriate for specific MSM and helping them to decide kind of which regimen is best for them. On the next slide, I just want to highlight, this is a really great video, and there's a link in the presentation to be shared. And I welcome you to check out this video on event-driven PrEP. And on the next slide, I just want to make give some thank yous. So this was developed with the US government interagency PrEP community of practice. I want to thank in particular CDC and the USAID key population teams and the USAID biomedical prevention branch. And then we have some on the next slide, we have some selected resources on event-driven PrEP. And I think with that, we can move over to some of the Q&A. So back to you, Christine.
Thank you so much, Chris and Gaston. There has been a very lively chat while you've been speaking. A lot of discussion around this question of eligibility and the fact that it's recommended, ED-PEP is recommended only for men who have sex with men only. And I know you have seen some of these questions and there's been some back and forth, and I'll read a few of them in the comments, but then maybe we could just allow our panelists to reflect on this topic as well. So while the question was, would other populations be eligible, the general response is that we don't have sufficient data on other populations to for the WHO to make recommendations. But some of the comments that I thought were interesting included the idea that maybe we shouldn't say that ED-PEP is not appropriate for other populations, but say that we just don't have enough research or data on other populations yet. I think there are some questions around whether there are efforts underway to determine the effectiveness of ED-PREP for other populations. There are also questions about whether it makes a difference if there is, if it's insertive or receptive anal sex. There are questions about what is the difference between anal sex between between two men versus a man and a woman in terms of why would there be a difference in terms of risk of transmission. So I just kind of put that whole body of questions out there and would welcome response from some of our panelists. You want to dive in, Gaston?
Yes. Hi, this is Gaston. Thank you for these pertinent questions. So I think one of the things that I know for sure is that there was a study done in South Africa among women on ED-PREP, and I think it was from Linda Gale Becker, and the results showed that it is not effective for women. It was done among, I think, high-risk women, and the result was it was not effective, and it has been published. Now, with the question of receptive versus insertive, we do not have any penile PK data, so we don't know actually for people who insert if ED-PREP is protective, but I think we know for sure that for receptive intercourse, it is protective. Now, the question that nobody really talks about is that, people are not having, how can I say that, behaviors of inserting or receptive. Sometimes people do both. So, no matter what, ED-PREP may be protective for people who engage in both insertive and receptive.
Are there others who'd like to comment on this question of why only men who have sex with men only? Go ahead, Greg.
In the Thailand or the IHRI experience, I think we are just following the guidance that because we do not have enough research, that we do not, until we have it, we do not want to recommend the use of event-driven PrEP in other populations. However, we have had instances where it has happened where some of our transgender women clients have started to use event-driven PrEP. They have said that they are able to plan for sex, and that it is only in the event of anal sex, whether they are pre-op, no-opt, or have transitioned. Most that have transitioned are taking daily PrEP. So while we do have recommendations to provide event-driven PrEP only for men who have sex with men, it does happen, and we haven't seen, so far we haven't seen any adverse effects, but I think in the future we'll be probably doing a study on this further.
I would like to add something. Actually, I think the review of data from the trial showed that the adherence among transgender was so low that they could not make any recommendation. So it may be working, but we don't know because those transgender participating in a trial were not adhering to to the drug. So you can't really make any inference for the use among transgender women.
Thank you, Gaston. We're going to go to Yanis Mamaletsis, who's with us from WHO Ukraine. Go ahead, Yanis.
Good afternoon. Good morning, everybody. Can you hear me?
Yes.
Great. Thank you for the for this webinar. Great presentations and great questions, actually, in the chat. On the point regarding kind of the use of 211 ED-PEP in women, I mean, it's sort of for a number of years, or I would say at the time of formulating the technical brief and before, and when there was sort of a series of consultations and discussions on the sort of pharmacology of PrEP medicines at WHO, I mean, there was that sort of kind of the ethical consideration in undertaking a clinical study around TDF-FTC with this dosing option. There was sort of sufficient data by that point to show that it would not be efficacious in providing high levels of protection in women. Given what we already know around tenofovir pharmacology, well recognizing based on the data that missed doses in cisgender women is a greater concern, in fact, than MSM. So I think, unfortunately, that's where things stand right now. I don't necessarily see in my viewpoint, a clinical trial in any time in the near future addressing 211 in cisgender women with TDF-FTC in combination. I would argue that maybe we do need in terms of, I think sort of broadly, this is a big point for transgender persons, transgender women and transgender men, much more data in the space of PrEP overall, but specifically on the use of tenofovir in combination with emtricitabine or lamivudine. I mean, I would welcome additional pharmacology data for transgender people. And I think there's, so it's not sufficient just to say that there's not enough data, we can't make a recommendation. I think we need to sort of really think about more strategically what kind of evidence could be generated, even indirect evidence, not necessarily a larger efficacy trial, in order to determine whether potentially 211 could be an option for transgender people. So that's the harder bit, to actually get some type of consensus on the way to address those research gaps. I feel it's insufficient where we are right now as a sort of PrEP community.
Thank you, Yanis. And just, one more comment from Sean Malone I saw in the chat, just to round out this particular topic. Is there any reason to think it wouldn't work in heterosexual men? We recognize that the pharmacodynamics and kinetics may be different in women, but for men, do we have any reason to think that it wouldn't work?
In my mind, not really. I would sort of, I think it's contingent on I think what would be important is to, because we don't make that differentiation for MSM for a top or a bottom. And so it's, you would prescribe somebody who's, an MSM who's, just having, having sex as a top, 211 as well. You don't make that you don't make that differentiation at sort of at the clinical encounter with a client. So I would welcome maybe a bit more, pharmacological data from penile tissue. And again, I think that's, that's a sort of quite an absence of data right there for those, for that population.
Yeah, and Jason, do you want to comment on this? Jason Reed is also one of our panelists from JPIGO.
Yeah, sorry, I was typing too quickly and had a misspelling there. I was just, as Giannis was talking, I do think it's possible and logical to believe that the drug may concentrate differently in vaginal versus penile versus rectal tissue. I mean, I think the belief is that event-driven PrEP works for MSM primarily who are at risk from rectal exposure because the drug concentrates so rapidly in rectal tissue, and that the same was not seen for vaginal tissue. Whether penile tissue and vaginal tissue are more similar to one another compared to rectal tissue, from an embryological standpoint, seems possible. So I was just offering, I do think that there is reason to believe that there would be differential or a different level of protection in terms of speed of protection, primarily, if your exposure is vaginal or penile versus rectal.
Thank you, Jason. Another question that has come up is if the 2 pills loading dose is sufficient for ED-PEP, is it not then also sufficient for MSM for daily dosing?
Hi, Christine, I really like this question. So in the July 2019 guidance that came out on event-driven PrEP, it is recommended that all MSM, regardless of event-driven or daily use, begin their regimen by taking 2 pills between 2 and 24 hours before having sex. So for MSM, it is effective when they're starting daily PrEP that they can take 2 pills between 2 and 24 hours before that first time having sex. And then for MSM who are taking daily PrEP, who decide they want to stop taking daily PrEP completely, they can stop taking daily PrEP by taking those 1 pill each day after for 2 days after the last exposure.
Very helpful. There are some other questions raised around planning, I guess, drug forecasting and planning. How, if we don't know, if we don't have a specific metric for ED-PEP, how does this affect the ability of the government or whoever is procuring product to determine, what the supply should be? I have a feeling there's no answer to this, but go ahead.
Yeah, the answer is that there is no answer yet exactly. I think that we're still trying to figure out, for MSM who are using daily or event-driven PrEP, what proportion of what time are they using event-driven versus daily PrEP? Are they on event-driven PrEP the entire time? So I think it's going to be extremely challenging to answer that question. One thing we do want to recommend is that regardless that clients have enough drugs between visits, should they decide that they need to take daily PrEP. So I think that keeping in mind kind of shelf life of drugs and kind of the need for daily oral PrEP, there has to be kind of a happy medium. And then this is also an opportunity for programs to collect information on, how many MSM are interested in event-driven PrEP and maybe express that that's their primary way of using PrEP.
And then this leads to some other questions around prescribing, follow-up, monitoring of ED-PEP users. How does one prescribe it? How do you know how much to prescribe? How do you do the follow-up? How do you monitor adherence? Do we need to monitor adherence?
So currently we, the recommendation seems to be that there's just the same frequency of visits in terms of HIV testing, any type of like baseline labs that are being done. They follow the same whether it's daily or event-driven PrEP. With adherence, I think for both daily and event-driven PrEP, it's not so much about kind of monitoring adherence, but supporting effective use. And that's where I think those, those client and provider relationships are super important, so that clients can actually speak with their provider openly and honestly about challenges they're having with using PrEP effectively, so that the provider can help the client to figure out how best to effectively use PrEP long term. Also, I saw there's a question about whether condoms should be used with event-driven PrEP. I think as with daily PrEP, we would recommend that clients who are using any type of oral PrEP use a condom when possible to prevent against other STIs.
Thank you. Yanis, I'll let you go ahead and respond, and then we'll move on to our next presentation. Go ahead, Yanis.
Oh, great. Thank you. And to Chris's point, I think it's just really important to on the point he made around the provider-client relationship. I think it's just key to ensure that the literacy around PrEP is maintained and strengthened during somebody's PrEP use. So it's so I find that's very critical. I mentioned it in the chat as well. You obviously sort of, if you have a large program of PrEP users, you want to be be paying attention to any breakthrough HIV infections. And obviously, every time somebody comes back for a refill or whenever a follow-up visit is, whether it's in person or virtual visit, you just really try to ask people about their current past experience in using PrEP either as 211 or daily, and enabling people to make that switch. The dichotomy of 211 versus daily dosing, I think, is a little bit limiting. It's really about effective use, as Chris mentioned. Maybe we can speak a little bit more to that concept. Thank you.
Thank you, Yanis. And thank you very much, Chris and Gaston, for the presentation and the robust conversation. I note that there are a number of hands up among our attendees, and I would just ask that you would please put your questions into the chat to all panelists and attendees. You'll notice that some questions are being answered as we go in the chat, but we will also be putting together a resource sheet after this webinar in which we answer all the questions, and we will send that back out to you. I have to admit, it usually takes us about 2 weeks to get all those questions answered, but we will get that information back to you for those questions that we weren't able to get to today. I think it'll be really great now to move on and hear from Greg Carl about the experience with event-driven PrEP in Thailand. I think sometimes hearing how it actually works in program really gives us a much better sense of the practical implications. So over to you, Greg.
Okay, thank you very much. And hello, everyone. Hello from Thailand. I'm pleased to be here this evening here in Thailand to talk about our experiences at the Institute of HIV Research and Innovation. We are a new organization, but a long history. We used to be the prevention and search units of the Thai Red Cross AIDS Research Center, which you may be familiar with. So let's go to the next slide, please. Okay. I was asked to look at what the Thai national guidelines say on PrEP, and we've been a little bit slow to introduce PrEP into our national guidelines. National guidance on PrEP first appeared in 2017 and basically just introduced the key populations that would be or should be eligible for PrEP. And this is, the meaning here is only for daily PrEP. Event-driven, which we call on-demand PrEP here in Thailand, was introduced in 2019 to target men who have sex with men who do not want to take PrEP every day, can plan their sexual encounters, and perhaps don't have sex every week. So here I've highlighted the men who have sex with men in the middle. The guidelines or the programming that we do at IHRI take a lot of our guidance from the IPRGAY study that was mentioned earlier, and also the WHO technical guidance that came out in 2019. Okay, next slide, please. Our approach to PrEP delivery is through key population health services, which are services that we have assisted in establishing. They are designed and co-delivered by the key populations. The populations that we've concentrated on most have been men who have sex with men and transgender women, but we also focus on other populations to some extent, transgender men and people who inject drugs. In key population-led health services or under linkages and EPIC daily PrEP and event-driven PrEP are delivered through the Key Population Health Services. They were formerly drop-in center services run by Key Population Services for sex workers, men who have sex with men, and transgender, that were then later converted into community-based health services. The services are provided not by medical personnel, but by key population lay providers that have been trained and certified. Okay, next slide, please. And so we get a lot of questions. Well, what about the efficacy and the quality of services if they're provided by non-medical service providers? But actually in the area of HIV testing and PrEP delivery, KPLHS services have played a significant role in the delivery or the rollout of services to these populations. So here we see that 55% of MSM and transgender women were tested by KPLHS services in 2018, and 55% of PrEP users in 2018 received PrEP through the KPLHS services. Okay, and these services have provided daily PrEP since January 2017 and event-driven PrEP since June 2019. Actually, they were providing services before 2017, but they were in conjunction with like referral to government clinics and also to the Thai Red Cross AIDS Research Center. Okay, next slide, please. Okay, and here, the national targets for PrEP are quite high. They're based on our population estimates for our key populations. So 143,948, as you can see. So far, we are not doing so well in terms of reaching the national target. We are only reaching about 18,500 individuals. But what is significant here is that the majority of PrEP delivery is through the key population-led health services. The black area that you see below is actually, it says PrEP 30 and PrEP 15. I'll explain a little bit. There are services that were initiated by the Thai Red Cross AIDS Research Center, providing generic brands of PrEP. Here they're called Tino M and Tino F. So the cost is approximately $1 per day or 30 baht, or versus 50 cents per day or the 15 baht. So PrEP 30 and PrEP 15. This cost includes all HIV testing and other testing for kidney function and hepatitis throughout the delivery of the PrEP. So whether you're a new client or are taking PrEP continuously, that the cost is, I guess, feasible for many who do not want to be, perhaps don't want to be registered in any type of government service. They prefer what they assume is a greater sense of anonymity. The blue-green area is a program that is provided by the Princess PrEP program, which is a program that is sponsored by Her Royal Highness Princess Somsawali, which actually provides free PrEP to key populations throughout Thailand. And this was also originally distributed or delivered through the Thai Red Cross AIDS Research Center. Then later, as key population lay providers the centers became legalized to deliver PrEP, that soon the responsibilities were transferred from the Thai Red Cross to the key population services themselves. The light green area, or the kind of yellow area, is is what we call PrEP TaiNet, which is PrEP funded through the Global Fund and US CDC. The primary recipients, they receive their PrEP through government-based services. And then finally in the Orange service, starting in July 2019, the National Health Security Office, which is the primary health service funder in Thailand, started providing for free at this time through various services, both government and key population-led health services. And within the service, within the numbers receiving PrEP in this area, 13% comes from the key population-led health services. So in total, KPLHS are providing about 58% of PrEP delivery in Thailand at this current time. Okay, next slide, please. To describe KPLHS services and services provided by KP-lay providers, I'll provide a little bit more detail. The KP-lay providers under the KPLHS model conduct risk assessments and provide PrEP counseling to the client, and the HIV test is also conducted, sometimes by the counselor, other times, depending on in mobile services, other times there is a medical technician within the drop-in center services. Blood samples for creatinine and hepatitis serology are sent to outside laboratories. But in our services, we try to provide PrEP on the same day to prevent against client loss. So the client will go through the counseling service, they will receive their HIV test, and then also the blood samples will be taken for the kidney and liver function serology, but they will not get the results for liver and kidney function on that day. If there is like warning signs with the results of those tests, the client will be notified to come back for further consultation to the key population-led health services. But first, before they receive the PrEP, their HIV status must be confirmed, and then PrEP is dispensed on that day. The PrEP is dispensed through a standing order through a medical service provider with a linked hospital or other medical service. And the results, as I mentioned, the results of the liver and kidney functions are then, consultation is conducted with the doctor on whether or not the client should continue with the PrEP. And if there is any indication of a problem, that they're asked to come back for further consultation. To become a KP-lay provider, CBO staff must be nominated by their organizations. They must then complete approximately 80 hours of training in HIV counseling, including training on both daily PrEP and event-driven PrEP. Then they must pass a number of theoretical exams and complete with a score of 80% or higher. After that, they must complete a 90-day practicum where they do both observations of skilled lay providers, and then they are observed in providing their own services before they are assessed for, they receive a competency assessment and certification. So it's quite a detailed process, but we want to ensure that our KP-lay providers are providing a high quality of service. The certification initially is valid for only 1 year, but then in each renewal, certification will then be good for 2 years thereafter. Now certification of KP-lay providers has become a criterion for accreditation of the KPLH services and for reimbursement of the PrEP services that are provided under the Universal Healthcare Scheme. So the government provision of PrEP for free to key populations. Okay, next slide. Here we can see from June 2019 to December of last year, the proportion of clients selecting daily PrEP versus event-driven PrEP. So far, event-driven PrEP is not the preferred method of taking PrEP in Thailand. Part of the reasons for this may be that there's still not enough knowledge among men who have sex with men about the availability of event-driven PrEP and the benefits of event-driven PrEP. But as we can see here, that the majority only of this number after the 1 month return visit, only 199 persons were taking event-driven PrEP at that time. Okay, next slide, please. Here is just some reasons that have been given for why clients have chosen daily PrEP over event-driven PrEP. I think most of all that the clients are saying that they have frequent sex, that event-driven PrEP is just insufficient for their needs, and that others are afraid that they will be unable to take the event-driven PrEP correctly. So the big issue is that planning for sex. You know, are they able to plan when they will have sex? Are they able to take it 2 to 24 hours in advance? You know, are they able to postpone sex, you know, for 2 hours in order for the PrEP to be effective? So most tend to choose daily PrEP because they can they find it easier to remember taking the PrEP the same time every day. Other issues are related to either taking substances in conjunction with sex, or engaging in group sex or sex work, where it becomes difficult to plan for sexual encounters in advance. Okay, next slide, please. Some of the reasons for choosing event-driven PrEP, clearly that they are individuals that have have sex less frequently, as mentioned earlier this evening, that maybe they have sex maybe once a week, or less than 2 times a week, or perhaps less frequently than that. Others are afraid, they have heard mostly through the internet that taking PrEP long-term can have a negative impact on liver and kidney function, and so they would rather take event-driven PrEP in order to protect their health in other ways. Some of the reasons that were given are actually the same as for choosing daily PrEP, but they're in situations in which perhaps they have advance notice of when group sex or sex parties may occur. Some of the very reasons are used for both deliveries of PrEP. Some are very different reasons, but in all, for event-driven PrEP is that they are able to plan for sex and are able to manage and taking PrEP as appropriate. Okay, next slide, please. Okay, and so for PrEP, both daily PrEP and event-driven PrEP, we have initiated some strategies to try to increase the uptake. As I've mentioned earlier, that more than close to 60% of the PrEP delivery in Thailand is done through the KPLHS, but we're still not hitting the targets of the government targets for PrEP delivery. So as was mentioned earlier, we try to make clients aware that that there's a lot of flexibility, that they can switch between daily PrEP and event-driven PrEP as their behavior changes. And as circumstances may also change, that we saw that during COVID-19 in the past year and a half, that many of our clients have switched from daily PrEP to event-driven PrEP just because they were having fewer sexual encounters. Some have stopped PrEP altogether because they were really felt that they were not having sexual encounters, or they were not planning to have any sexual encounters. We also took a look at how we are framing our messages for PrEP during the counseling services, and also any promotional messages through various types of social media, which I'll talk about in a moment. Oftentimes in the beginning, a lot of our service providers would do the risk assessment and immediately recommend, oh, you are at risk, you should take PrEP. So really putting PrEP in a negative frame, which would give rise to feelings of guilt, self-stigma, and really be counterproductive, that clients would really not wish to take PrEP, or they would say that, oh, well, I'll take my time to maybe consider it. The other strategy would, as I mentioned earlier, with that we try to provide same-day PrEP service so that clients do not have to wait several days or a week before starting PrEP, that they can start immediately. Also providing express and telehealth service and mHealth services, which I'll explain in just a moment, and also public and social media campaigns to promote the uptake of PrEP. Okay, next slide, please. Okay, also, I guess in taking a look at PrEP counseling first, that clients, of course, must undergo PrEP counseling, that the PrEP counseling is incorporated into our HIV test counseling. And this is just highlighting some of the key points within the HIV counseling where we were providing PrEP counseling. So first, it's necessary to conduct risk assessment. This is because a detailed risk assessment is needed is encouraged, because clients must not only recognize the personal relevance of prevention information, but also to act on or initiate healthy behavioral practices. So they must recognize for themselves, rather than being told that they are at risk, and that PrEP may be an intervention that can help them. In pre-test counseling, we generally provide only basic information on PrEP. We don't want to provide a lot of detailed information, maybe providing a lot of hope before we actually have the test results. Conversely, that many clients may come in because they are interested in starting PrEP and they would like to have information. So in those situations, we will provide a bit more information on PrEP in pre-test counseling. For post-test counseling, again, the test result must be negative outside the window period, and there must be no signs of acute HIV infection. Providing readiness to start PrEP is assessed. We would like them to start straight away. But also, again, we look at special considerations. What are maybe the issues that may prevent the client from starting early, or different considerations, in terms of their living situation, maybe other concerns that the client will express in this situation. Then detailed information is provided on both daily PrEP and event-driven PrEP. and asking the client considered based on their risk assessment what they would feel would be the most appropriate form of PrEP for them. They provide consent for the liver and kidney function tests, and then PrEP is dispensed. And then they are contacted when the liver and kidney function test results are returned. Next slide, please. Okay, this is just included as examples of positive gain frame messages for taking PrEP. So rather than telling the client that, oh, you are at risk, you are at high risk, you should take PrEP, we try to put it in a positive light. It's not that we can't deliver say negative messages. I think we need to return to maybe the risk assessment, which may be seen as providing a negative message, but again, it's necessary for the client to acknowledge their risk and then to take action. But when we talk about PrEP, we put it in a positive gain frame message. Okay, next slide. And the results of the messaging, these are just some examples that they don't specifically target event-driven PrEP. Again, then the majority of our clients are still taking daily PrEP, but it's good to show that in our Tangerine clinic, our Tangerine clinic is a clinic focusing on transgender women and transgender men. In using gain frame messages and effective use approaches to PrEP, that the uptake of PrEP increased 284% from Q3 in 2020 to Q4 in 2020. So quite significantly. For effective use messages, effective use was described earlier, in which we look at adherence to PrEP. Are they taking PrEP, both daily PrEP and event-driven PrEP appropriately? Are they taking the 2 tablets at least 2 hours before initiating a sexual act? And are they following that up with 2 tablets after their last sex? And through also the positive gain frame messages and effective use messages, that you can see that the effective use messaging seems to be working, that we have higher than 90% effective use in both transgender clients and MSM clients. These clients are in all the KPIHS centers that we work with. So combined data, and as you can see, there's maybe some attrition in terms of PrEP use. A lot of the reason for this is that the data has been collected during COVID-19, and so a lot of clients have either stopped having sex, or their sexual behavior has reduced. So many clients have stopped taking PrEP during this period. Okay, next slide, please. I mentioned that we have also the Express telehealth and mHealth services. Express service have been set up to expedite steps in clinical service provision, so that clients who are regular clients, they don't have to go through, they may do some of the service processes online, so registration. They may also have online pre-test counseling before coming into the centers for their blood tests. And then they can receive their test results for both HIV and for the liver and kidney functions through online services. The telehealth services are similar, but the services for our role in the service provision is done mostly online. So it would be online registration, online counseling, but then the client may be attending, have their blood testing done at a clinic close to home, but then they receive their PrEP through our KPLHS services. So this helps us expand our service net greatly into districts and even provinces where PrEP is not yet readily available to clients. And then we also have mHealth and mobile clinical services, which mimic the express PrEP services, where a number of the services for regular clients can be done online. And then they drop into one of our mobile services that will take place at an appointed time and an appointed place and receive their PrEP. Okay, next slide, please. And then finally, that for demand generation, we have a number of campaigns. We haven't had a campaign specifically for MSM for PrEP, but for transgender clients, we've had citywide PrEP campaigns that provide health, again, health empowering gain frame messages that focus on the positive rather than risk reduction messages. And then also providing messages through YouTube video spots, through Facebook and Twitter fan pages, providing positive messages, and then also through, it was mentioned earlier, Grindr. There's a popular dating application in Thailand and other countries as well called Hornet, where clients can be linked directly with our KPLHS service providers. Okay, and then last slide. And in conclusion, again, that our delivery mode is through the KPLHS services, services provided by key populations for key populations. They have been very effective in terms of our PrEP rollout. So again, more than 58% of PrEP has been delivered through the KPLHS services. The KP-led services are free, and also the PrEP can be received on the same day, so fewer clinical visits. And that we are trying to provide more PrEP choices. So again, providing both not only daily PrEP, but event-driven PrEP. And then also providing gain frame messages, across the board in our counseling services and also in our promotional messaging about PrEP to help reduce PrEP-related stigma among both MSM and transgender clients. Okay, thank you very much. And I'm way over time.
Thank you, Greg. That's great. I mean, it really is if I understood you correctly, ED-PEP has pretty much been scaled up across all of these programs, all of these lay delivery programs. Is that correct?
Yes, all of the services that are under the EPIC project are providing ED-PEP services. That ED-PEP is an option, but it's up to the client to choose which option they would prefer. But I think in the future, we will be doing more to promote ED-PEP, because in the data that I showed you with the circles earlier, why they chose daily PrEP over ED-PEP, that a lot of MSM are just not aware of ED-PEP. They are not sure that they can manage, taking the ED-PEP effectively. And also they're concerned about, the health issues related to ED-PEP. But now we're looking at how we can work with that and maybe increase the uptake, because a lot of the clients really do not, are maybe not at risk or have sex frequently enough that they require to be taking daily PrEP. But I think that, you know, a lot of the clients just say that it's easier to remember one tablet a day, you know, taking it together with their vitamins, or in the case of daily PrEP for transgender clients, that, you know, they can take it together when with their hormones. So we do a lot of hormone, we also provide for the transgender client, we provide hormone testing and hormone delivery services as well.
Yeah, so I think these data are going to be very important because you're kind of ahead of some other areas of the world in terms of, you know, learning what factors the clients consider in terms of choosing ED-PREP over others and what their experience is, and that's going to be very helpful for other countries that are considering ED-PREP. I thought I might just, since we only have a few minutes left, I just wanted to ask, I think it's Patrick that we have on from USAID. I just wanted to ask about if you could share anything you know about, or maybe Chris is the better person to answer this, you know, the efforts now to roll out ED-PREP in some African countries. Do we see where there is momentum and what some of those considerations are?
Yeah, I'm happy to start, and Chris can follow on. Yeah, just to note, I mean, these are ongoing discussions right now, definitely in real time. And just to note, I think Giannis mentioned this, and Greg. I mean, there's been, you know, the heavy lift really was, I think, getting daily PrEP approved, and that's even happening currently in many countries. And so I mainly backstop West and Central Africa, and so that's happening in real time. You know, recently Ghana implemented PrEP, and there are ongoing discussions around ED-PREP, and so that might be a good example to see where once there's already this understanding of daily PrEP among stakeholders with Ministry of Health and NAC. You know, the multilaterals, you know, kind of like what Giannis mentioned, it may not actually be that difficult to provide an update just based on WHO recommendations. And then going from there, obviously, we'd want to see, you know, a more broader scale implementation, you know, getting providers ready, getting, you know, that understanding in the community. We already have demonstration projects like Côte d'Ivoire and Abidjan at Clinique Confiance the last few years. You know, already we have you know, the sort of early adopters who are gathering the clinical data, and that certainly helps for the country level stakeholder discussions. But yeah, I mean, this is definitely real time, and you know, as we saw, Gaston mentioned the global COP guidance this year is mentioning ED-PREP as an option for MSM. So we definitely anticipate, I think, probably in the next year that we're going to see many more countries starting to include it in their national PrEP guidelines. But yeah, it's really real time. Of the countries I support currently, ED-PREP is not approved in West and Central Africa, but that mainly reflects it's just taken so many years of effort to get daily PrEP off the ground. And you know, once that's there, we think it'll be more likely to be up and running. But yeah, I can pass it over to Chris if you have other specific examples you want to discuss.
Yeah, so I think Ghana will be, you know, is moving towards implementation. It's actually already written into their guidelines, even though maybe not quite very descriptive. I think Cameroon is looking at implementation very soon. I think an important thing to point out too is that MSM talk, they communicate, they have networks, and so whether it ends up in guidelines or not, MSM will attempt or will use event-driven PrEP. And I think from a health perspective, what we want to make sure is that, you know, while guidelines are being put in place, if MSM are using event-driven PrEP, that they have access to information so that they can use event-driven PrEP effectively. I think that's a really important piece, is that, you know, whether it's being implemented formally or not, MSM are using event-driven PrEP, and we want to make sure that they have the tools to use it effectively.
Gaston, did you want to weigh in?
Yeah, you know, I wanted to second what, you know, Chris and Patrick said, but I think we have the right opportunity right now that, you know, we're going to have COP meetings to kind of re-put the issue on the table and push for that with all the stakeholders. Another thing that I wanted to say is that, I think there is one country in Asia that was successful in putting that in their national guidelines and implementing it, on an interagency basis. It's Vietnam. They are kind of currently doing that. It's officially in the government. They have, those guidelines.
That's great. Well, I think that was the point of this whole webinar today, right? Is to try to increase knowledge, awareness, and hopefully catalyze action around moving forward with event-driven PrEP in more countries and regions than we have now. We certainly have a lot of questions. I know we were not able to answer many of them, but as I mentioned, we will get to them in a written response within a few weeks. If you could go to the next slide, Casey. And next, yeah, I just want to remind everybody that all of our webinars and materials and PowerPoints are available on the PrEP Watch Virtual Learning Network site, so you can find a recording of this session, and we will also put the resource sheet there once available. I really thank all of our speakers, Greg and Gaston and Chris, and our panelists, Giannis and Patrick, for being here today to answer questions, and for all of our attendees for joining. We will have our next session in April, and that will be focusing on PrEP continuation and prevention effective use. And then we have been having these webinars every month. We're going to start spacing them a bit to every other month. So please be sure to go on the website to sign up for our April, June, and August webinars, even though our June and August ones, the topics have not yet been determined, but we will get those up there shortly. Next slide. I guess that's it. All right, well, I just thank everyone for joining today. I wish you a wonderful evening and day, and look forward to seeing you next month. Thank you.
Thank you, Christine. Take care, everybody.
Take care.
I know people are dropping off. This is just a comment to Greg. Fantastic presentation, great work in Thailand. And I think your KP training, I think would be a super wonderful template and model for so many countries to undertake. And kind of when you were describing the sort of 80-hour training that you do for in your setting, I just would love to see that kind of copy pasted or a generic template of that for the world.
Yeah, we're working on that. One thing in terms of like the PrEP, we've been asked to most things have usually been from the government to the community services, but actually things are working in the opposite direction because we've been more successful in PrEP uptake, that we've been asked to conduct training for government officials on PrEP counseling. So it's really positive. So it's another way that we can try to increase PrEP uptake through the government services and not just try to duplicate our services everywhere, because that's not entirely possible in all areas of Thailand. And so it's something we're really looking forward to in the very near future. And we're also, I was in communication with Katie, and we'll be providing kind of a practical guide on gain framing messages for PrEP that may help in counseling sessions. I mean, it's not, it's not for everyone to adapt, but it's just to give everyone an idea what type of message they can use on each stage of readiness, per client stage of readiness, I guess is what I want to say.
Okay, great. And there's sort of we've with the demonstration project in Sri Lanka, uptake is slow. It was challenging to try to get 211 in the actual protocol for the demonstration project, but we did, and it's because the community wanted it, and there were also kind of clinicians that felt, you know, it was important, and I just said it's global guidance and it's just best practice, and it should just be integrated right from the beginning, rather than saying, oh, we'll go with daily and then phase in the 211 option. I think when you're starting off a program, you should, at this stage in 2021, based on all the evidence we have. I mean, and I posted a link to Jean-Michel Molina's Prevenir update from CROI from last month or this month, yes, whenever it was. And yeah, they've just they've shown it's, you know, the HIV breakthrough infections, there were breakthrough infections, the HIV infections, there were 3 in daily users, 3 in 211 users. So I think we need to be careful, you know, to just the marketing of 211 as a safe option. We just need to keep reinforcing that, I think, to decision makers and also PrEP users. And then obviously the more, what you spoke to, I think the right messaging. I really liked Chris's different scenarios and visuals. All this is, you know, I think these are tools that sort of in the clinic and online need to just be made available and, you know, kind of, I would say, updated and just made much more clear to end users.
Yes, exactly. Yeah, there's still a lot to do here in Thailand. I mean, it is in the national guidelines, but not just very lightly so. I mean, it's the problem, I think, is in terms of funding that the National Health Security Office has not yet supporting event-driven PrEP. Again, I think they're not clear on how to do so, that it might be a waste of funding, you know, just dispensing bottles of medicine. But the fortunate thing is that we have the Princess PrEP program, so that while the government is taking up the cost of PrEP, although slowly, that Princess PrEP is still there to take up the cost or absorb the cost of event-driven PrEP. So we have that, you know, it's a positive option here in Thailand, so that cost is not really an obstacle.
Great. I think we're technically, you know, obviously we've completed the session. I just want to thank you again, Greg. I just wanted to sort of just stay on and chat a little bit more before I go to my next call. I also see my colleague, Dr. Satya from Sri Lanka, who's been very instrumental in leading the kind of the PrEP introduction in that country. And I think it's sort of, we start slow, but you know, then we want to pick up pace, obviously, with our implementation. And I think there's a lot of other kind of colleagues, participants on this webinar from countries where, you know, PrEP use access is limited right now, but, you know, we need to look forward ahead to better days. So, thank you, everybody. Have a nice afternoon, evening to everybody. Take care.
Thank you.
Thank you, Greg.